the hell's going on?
We got all these wine bags in here today.
Oh, you're the one whining about getting hit by the deer. Oh, my leg.
It's a legitimate wine.
Mine's legitimate too.
I wasn't whining. I was just telling you.
I'm trying to pass my classes.
Share, present to everyone. All right, we're live, so don't talk bad about anybody. Today is 4/20, so it is a pot smokers holiday.
It is a what?
Pot smokers holiday.
Oh, it is.
Mm-hmm.
Got some?
Mm-mm. I left that back in college.
I didn't leave in college. I went to school.
All right. So we're on cardiac emergencies. We're through cardiac.
We have the wrong chapter downloaded. We gotta go.
No, I got it. We're through cardiac emergencies. We're on 19.
We're to the first chapter of review. Oh.
Yeah. Oh, yes. All right, here we
Is
are.
he gone? So you're happy too? Yeah, he left today.
So Ellen went on a call with me the other day, and I showed her exactly how not to run a call. So yeah, it's been a long time. It's been a long time since I ran a call. But anyway, so what brought this up is other causes of altered mental status, right?
Yes, he was so cute. I'm like, what year is he? 1970, 30. He's on that religion. Yes, you are.
Yeah. So he has an altered level of consciousness. He is not A&O times 4. Thought the president was Obama, so he's confused time and event. We didn't, and we stopped right there. We didn't.
He knew his name.
He didn't know his name. So yeah. So we left it there, but you know
His O2 set was great.
yeah, 98%. So anyway, he has an altered level of consciousness, and it's not typical for him. Talking to the family and stuff. This is different. That's why they called. They said he's not feeling well. He said, "No, I don't really feel well." Pain in the side. You know, and so we're just running the call, and I just kind of got sidetracked doing other things. And anyway, about the time we enter Alex City, I said, "Hey, I'll go ahead and just throw him on a monitor real quick," because we hadn't put him on the monitor. And yeah, one thing. And anyway, so I mean, we knew his blood sugar was good. So anyway, his heart rate was about 160, 170, which I kind of expected because he was on a medication that controls that, and he hadn't taken his medication since Saturday. But if I would have been on my game, I would have went ahead and treated him with Cardizem, because we had it, and I would have treated him. But by the time that it really kind of clicked and I went back into paramedic mode versus trying to teach an EMT, we already entered LC. I mean, we didn't have him that long. Look at the times. From the time we had him to the time we dropped him off, it was 30 minutes. You know, and that's from Hammond to LC, 30 minutes. You know, we did start an IV. We did everything up until the point of where I should have given him Cardizem. And we did give a fluid bolus, which probably should have came first anyway. And maybe we should have given him a little bit more fluid, but anyway, kind of goes along with that altered mental status. There was a reason that he had an altered mental status. Most likely it's because he's probably slightly hypoxic, even though his O2 set reads okay. But his like for his brain and stuff like that, he's probably not getting all the oxygen that he needs. And so he probably was in an accelerated or AFib with rapid ventricular rate for quite a while. So anyway, and then the day before, where was all my students at? We run a code, an actual real, did some CPR and a bacon, all kinds of fun things. Nobody went on that one. But
As soon as I get out of school, I'm gonna go. As soon as I get out of school.
so speaking of that, you guys have to get, you guys really need to start riding or coming in and do ER time, because you have to have 36 hours by June 30th. So that's a lot of time, and it sneaks up on a lot of people. So if you can, so Ellen probably already has, what, 15, 16 hours with the classes she's done, or the rides that she's done. And the patient contact. So, you know, now she could probably go say that she's doing ER time and stuff like that. We'll have to do the paperwork to see exactly where she is. But remember, you have to have those 36 hours done by June 30th. So
This weekend might be a good time to get some time in.
Heck, yeah, we're gonna have people all over the place. We're dropping dead. We're not dead, but dropping.
you know, believe it or not, the increase in people really doesn't affect us that much.
I guarantee you, someone's gonna fall off their horses in barrel racing tonight. I guarantee it.
You think so?
Barrel races are fun as hell.
So wait a minute, they're doing barrel races tonight?
Just it's a different deal though. The Cowboy Church is doing a barrel race up there tonight.
I'm surprised.
There'll be 2 or 3 fall off at the first barrel.
Okay, so I'm surprised that they didn't call for an ambulance, because most sanctioned or most events.
You don't have to barrel race. Have an ambulance there.
That's crazy.
Even at bull ridings now, you don't have to have an ambulance present as long as you have an EMT there.
Whatever.
That's and most people have an ambulance. Yeah,
Yeah,
they're sitting on the ambulance this weekend up here.
what's that?
They're sitting on the ambulance this weekend up
I
here.
don't know people.
I
I scheduled some people to
mean,
do
the
it.
rodeo will stand by the ambulance, so that kind of ambulance. I'm
It sure does.
like, okay, I'm here. Because I guarantee you someone's gonna get hurt. It's probably gonna be the Queens tomorrow night. The Queens always fall off their horses.
Yeah.
Doing their little thing and their horse flips out and they fall off. I love it. She's not Queens. Yeah, but those princesses fall off too. Even though you know how to ride. I
So-
was raised on horses. You know how to fall off?
So anyway, please make sure you start getting your hours in, guys. It's going to be here. The end is here a lot quicker than you realize. Think about it. We're almost done with April, May, and June, and time is going to fly. So, yeah, I mean, you think about it. We started beginning of March, and now we're over halfway done with the class, which I'm going to stop teaching until Western Tech pays me. They still haven't paid me. You know, you guys all paid your tuition.
Oh, well, that's gonna be good. You quit teaching them.
Just kidding. I'm not kidding about them not paying me yet. Check my freaking bank account every day. I'm like, where the hell is this money for these classes? So,
You get, no, I'm not asking what you get paid. Do you get paid decent to teach a class?
I make $30 an hour, but it's only for hours of teaching. And so, they don't pay you any prep time. So all the time I spent before we even started the class, getting class set up and everything,
That's why our classes are so short.
they make it up for it. Yep. No, it's because we get through the material we're supposed to get through. And if you're in my seat and you look out and everybody's like, I know that I've gone past your guys' attention span. And I know that Emilio's at his house just watching movies and stuff. He's not even paying attention. So anyway, please making sure you get those ride times in. We are going to do CPR Tuesday, so you guys will get your CPR certification. You'll be CPR certified as of Tuesday. It'll probably be a good 2 weeks before you get your card. And so please be here for lab on Tuesday. I'm going to see if I can't get somebody else to come in and run like half the group through a kind of mock scenario, kind of rotate through, so you guys aren't sitting around twiddling your thumbs. Well, we do, we might. three people to a little scenario, the rest of you'll just be sitting around twiddling your thumbs. So I guess you guys could.
That'd be a good time for you to do a test. if you're
I
gonna
think
do
it'd be a better time for you guys to grade the people doing it. But so anyway, that's where we're at. I still have yet to really look at the next couple weeks. Time's getting away, and I won't be here. I won't be at work tomorrow either. I have to go up to the city and pick up spine boards. You sent us a nasty email, so I'll be going to OU to pick up spine boards. So hopefully soon I'll kind of lay out the next, hopefully month for you guys. I think probably after this cardiac chapter, and this altered mental status, we'll probably pick it up a little bit quicker again. Try to get ahead again. We were to where we were about a class, the 2 classes ahead, and we're back on track, which is fine. That's where you guys are. That's where you guys are. So we just need to get through it so we could do our national registry stations and stuff like that. So anyway, I told you a little story about Ellen and I's other cause of altered mental status, and so we'll go ahead and continue on. So sepsis is kind of I'm not going to say it's a new thing, but sepsis is something that hospitals and EMS are really, really, really concentrating on right now. Probably a lot more people died from sepsis than we ever realized. And whenever the studies came out and kind of showed us that we miss sepsis so much, it's kind of I guess a trigger word now in hospitals and stuff that sepsis. And so they're doing sepsis training, getting it to the point where if they have a fever above 99 degrees and certain things that you're looking at sepsis right away. What's that?
I think my grandpa got it. He was just,
Yeah, it's quite possible. And the thing is it could be something.
I mean, it feels like that. If you feel it like that, can it?
Well, I mean, you get
Well, I mean,
sick.
it builds up.
Yeah, you get sick and you're sick for a while, and they're like, oh, it's just an infection or whatever. Typically, an antibiotic's given. They go home. They don't take it exactly like they're supposed to, or maybe it's the wrong antibiotic. They continue to get sick, and it's kind of a cascading effect. And then before we realize it, all of a sudden the patient has gone into sepsis, which
He went to the doctor and died 8 hours later.
yeah, well, I would say that if he died 8 hours later, he was sick for a while, if he was septic. But you're what's that? So Pearson steps normally taken to fight infection move from the local site and become a systemic problem. So rather than just like a UTI, and this is where a lot of them come, and I think I read in one of our sepsis modules that most sepsis actually comes from pneumonia, but where I think I see it more is in UTI. So they had a UTI, went undiagnosed, they had a fever, didn't feel good, kind of ignored it, and all of a sudden they have an altered mental status, and you find out they've been sick for 2 weeks, and now they're septic and they're in an ICU fighting for their life. And so kind of say, pneumonia, you expect somebody sick with pneumonia. They have a hard time breathing, they usually come in and they end up going septic, but maybe that's why I feel like, it's more the cases I see here with UTIs, because it's kind of a different etiology. So if severe enough, the microbes of the offending infection can release toxins that harm cardiac output. The following findings indicate severe sepsis: altered mental status, increased heart rate, increased respiratory rate, low blood pressure, high blood glucose, and decreased capillary refill time. I would throw that last one out, but you guys probably need to know it for your tests and stuff like that. There's so many things that could affect cap refill, from cold hands to poor circulation, that capillary refill is just telling you that they had a vasoconstriction, so there's not a lot of the blood flow into the extremities is not as rapid as it should be. But that can also be caused from a cold extremities or whatever. If normal brain function is upset by injury, infection, or disease, the brain's electrical activity can become irregular. Irregularity can bring out seizures, sudden change in sensation, behavior, or movement. Seizure is a sign of an underlying defect, injury, or disease, and not a disease itself. And so whenever you get that patient that has that seizure that doesn't have a history of seizure, they don't have a history of epilepsy or whatever. Maybe they've been sick with it's not me. Maybe they've been sick with UTI or something, and all of a sudden they're having a seizure. Yeah, then it's a pretty good sign that they possibly have sepsis. So, two types of seizures. You have a partial, affect only one part or one side of brain. Patient may not lose consciousness. Generalized, affect entire brain and affects the consciousness of the patient. And I think they're going to get more into different types of seizures, like tonic, clonic, or the full grand mal seizures and things like that. You say they do, Owen? Okay. Okay. Kids have the petit mal seizures, which the teacher doesn't think they're paying attention. Kind of find out they later on get diagnosed with having petit mal seizures or petit mal seizures, however you want to pronounce it. Basically, the brain's misfiring. They're just staring off into space. Do they go into? I don't know if they go into this with the aura phase, the seizure phase, the postictal phase. Certain seizures don't have all the phases. So, like the petit mal seizures don't have the aura phase or the postictal phase. They just have the seizure. So anyway, unconsciousness and major motor activity. So tonic-clonic seizure is unconsciousness and major motor activity. Tonic-clonic seizures are what you typically think of as a seizure. Somebody jerking on the floor, peeing their pants, biting their tongue, and going unresponsive. This is one of those diseases that I've seen more fake seizures than real seizures in my career. Why they do that, I'm not exactly sure. They actually have a diagnosis of pseudo seizure. And so what the thing is for us as EMTs, treat them all the same. As hard as it will be, you'll see the medics out there in the field dropping their hand on their face, and they won't hit their face, or flicking their eyelashes, and they'll move their head. Sometimes you tell them a scary story, like I'm going to stab you in the eyeball with this needle, and they're like, whoa, 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 whoa. But don't do that. A lot of times it's a psychological issue why they're doing it. They need attention or something in that matter. But, so the tonic phase, body rigid up to 30 seconds. Clonic phase, body jerks violently for 1 to 2 minutes. Most seizures that I come across, so people know they have seizures, they take care of themselves for the seizures, and you very rarely run them. But you will run real seizures every once in a while. Tonic-clonic seizure, so postictal phase, after convulsion stops, often slow period of regaining consciousness. This postictal phase after the seizure is it is where I talk about them being really confused. They don't want you approaching them. They're kind of leery of you. They don't exactly know what's going on, and you can see it in their eyes if they're confused. And you can see it in their eyes whenever they kind of regain full consciousness, because all of a sudden they're like, they're talking to you and stuff. Some seizures preceded by an aura. It's a sensation patient has just before it is about to happen. Patients may note smell, sound, or just a general feeling right before a seizure. And so
My mom could tell when hers was coming.
they actually have dogs that are trained. If they can sense the aura and getting that person to kind of a safe place to have a seizure, it's pretty cool. So
Mom said it felt like there was a metal rod going through the middle of her head, and it felt like lightning was hitting it.
yeah,
When she knew,
she's gonna have a
when
seizure.
she would get that little jolt, then she knew she better get right down somewhere.
Yeah. I don't know if they say there is or not, but like there's also, you could have an aura with migraines. So Jacqueline always could tell whenever she's getting rid of a migraine. It was she had a metallic taste in her mouth and stuff. Cause of seizure: hypoxia, stroke, traumatic brain injury, toxins, and hypoglycemia. So I'm always get real worried whenever I run like a 20 or 30-year-old person that has never had a history of seizures, and all of a sudden has a seizure. I always worry for that person, but I guess it could be toxins. They could have taken some good drugs or something. Brain tumor, congenital brain defects, infection, metabolic, and then idiopathic. Epilepsy, measles, mumps, and other childhood diseases, eclampsia, and then heat stroke. Those are all causes. I'd be aware of them. What was person doing before seizure? So, kind of on your patient assessment, you want to know what the patient was doing before they had their seizure. Exactly what did that person do during seizure? So you want to know that. Were they jerking, or was it just a partial seizure, which is an arm or something? How long did the seizure last, and what did the person do after a seizure? So you have a status epilepticus, where basically they'll have a seizure, they never regain consciousness, and then they'll have they stop, never regain consciousness, but then they'll have another seizure, and those are very dangerous. You need to address the airway in those patients. If you're present when a convulsive seizure occurs, place patient on floor or ground, loosen restrictive clothing, remove objects that may harm patient, protect patient from injury, but do not try to hold patient still during convulsion. Don't stick anything in their mouth. Don't try to pry their mouth open with a spoon or anything like that. If you're going to do airway management, a nasal airway would be good. And a bag valve mat. So protect airway. If no possibility of spine injury, position patient on side. If patient is cyanotic, ensure open airway and provide artificial ventilation with supplemental oxygen. You will not be able to get an OPA in this patient. They're going to be clenched down, and you just won't be able to get their mouth open. Don't try to force their mouth open. Don't stick anything in their mouth. Patient breathing adequately may be given oxygen by mask or nasal cannula. Treat injury patient may have sustained during convulsions and transport. So, status epilepticus is telling you about 2 or more convulsive seizures in a row without regaining full consciousness, or a single seizure lasting more than 10 minutes. A high priority emergency requiring immediate transport to a hospital and possible ALS intercept. Please call for ALS intercept in these patients. We carry benzos, and we could treat these seizures. So anyway, please call ALS so they can stop, and they can also address the airway issue a little better than just a DLS type. Is that enough? Not all seizures present or not all seizures present as generalized tonic-clonic. So not all of them are that jerking that we think of. Partial seizures, uncontrolled muscle spasm or convulsions while patient is fully alert. And then complex partial seizures, often preceded by an aura. Generalized seizure, so tonic-clonic seizure, absence seizure, or what I was referring to as a petit-mal seizure. I guess they're calling it an absence seizure now. Brief, without dramatic motor activity, temporary loss of concentration or awareness, may go unnoticed by everyone except the patient and knowledgeable members of the family. So, stroke. Yay, strokes. AHA is doing a huge push for stroke recognition. If they don't say it, and I forget to tell it, one of the most important things that you can obtain on a possible stroke patient is when was their last known normal. They have, I believe it's a 6-hour window to treat that stroke, and you have to have last known normal. So if they wake up with stroke symptoms, if they didn't go to bed with stroke symptoms, the last known normal was when they went to bed at 9 o'clock the night before. So they're already outside of their window. But stroke, death or injury of brain tissue from oxygen deprivation causes blockage of arteries supplying blood to part of the brain, and then bleeding from a ruptured blood vessel in the brain. Two basic ones: thrombolytic and hemorrhagic. So, signs: one-sided weakness. So hemiparesis is very common, but not always. So don't say they're not having a stroke just because they don't have it. They may not be able to see out of one eye. May just have slurred speech, all depending on where the stroke is. Difficulty speaking or complete inability to speak. Headache caused by bleeding from ruptured vessel. Less common, but very important. If the patient tells you that I am having the worst headache of my life, consider it a hemorrhagic stroke until proven otherwise. All right. That's typically the sign they have, and then they'll complain of dizziness. So we had one not too long ago here where the guy called his wife, like, I don't know if I'm gonna be able to make it home. I'm so dizzy. I'm having the worst headache of my life. He had to pull over. He threw up. He gets home. He stumbles to the bathroom, dizzy and unsteady gait, and he goes into cardiac arrest. She goes and gets the owner of the ranch to their ranch hand. 10 minutes away, comes back. He's like, oh my gosh, got to call an ambulance. So he's already been down for 20 minutes. By the time we get there, it's another 20 minutes. So he's been down for a good 40 minutes by the time we got there. There's absolutely nothing we could do. Typically, once that ruptures, typically there's not a whole lot that can be done, depending on where that is. So.
I was glad I woke up at 3 o'clock in the morning. I heard that I was dead.
Yeah. So other signs and symptoms are confusion, dizziness, numbness, weakness, or paralysis, usually one side of the body, loss of bowel and or bladder control, impaired vision, high blood pressure. I don't see slurred speech yet. Difficult respirations or snoring, nausea or vomiting, seizures, unequal pupils, headache, loss of vision in one eye, unconsciousness is uncommon. Okay. What's that? Skip the slurred speech. Some other things: unequal grip strength, and you can see that. So communicating with the stroke patient, often difficult to communicate with the stroke patient. A lot of times they have slurred speech. Sometimes they don't have slurred speech, but they can't answer your question. It's like, hey, Ellen, are you hurt anywhere? Cat. And they get very frustrated because they're trying to answer you, they're alert, but the words aren't coming out of their mouth correctly. And it's kind of a weird deal when that happens. So, and you can tell they get very frustrated. The best thing to do for them is not to keep asking the questions because it's funny, but to just say, hey, just sit back, take it easy. We'll take care of you, okay? And don't ask any more questions because they're not going to be able to answer your question. I've had one patient in my entire career that we go slurred speech, facial droop, the whole 9 yards, and on our way in here to the hospital, is here in Roger Mills County, everything cleared up. They had a TIA, and it was on one hand, it was a very cool experience to run that because it was almost immediate. It went from blah to hey,
Was that my grandma?
it could have been. No, I don't remember who it was.
I had her in here the video time. She really was having strokes, but she would clear up.
It's TIA.
But I mean, eventually I took her to the city, and I told them she needs stents. She needs them now. They waited. She had a real bad stroke.
With
And then what they do?
with TIAs, it's not if they have a stroke; it's when they have a stroke. All the signs and symptoms and etiology are exactly the same as a stroke. The only difference is for whatever the vessel unspasm or whatever, blood starts flowing again, and it clears up within 24 hours. So anyway, if they start talking again, that's cool. You could start asking questions. But if you get that patient that can't answer your question, don't frustrate them and try to make them answer questions. It's not worth it. Damage to the brain can cause partial or complete loss of the ability to use words. Aphasia, general term meaning difficulty in communication, so they have a hard time communicating. Small clots are temporary block circulation to part of the brain and cause a stroke-like symptoms. Symptoms resolve when a clot breaks up. This is TIA, by the way. Complete resolution of symptoms without treatment within 24 hours, but usually much sooner. Above what you guys didn't know in here, but just for your information, a lot of times the patients that have TIAs also have a heart condition called atrial fibrillation. So basically, clots are created in the heart because the atrium are quivering versus beating like they're supposed to. And so it creates little clots, and they throw them, and that's a common cause of the thrombus for these patients. But, and so that's why AFib is really important to get treated. Cincinnati Pre-Hospital Stroke Scale. This is the one that we use. There's a lot of different stroke scales, and whenever I talk about Cincinnati Pre-Hospital Stroke Scale, I always throw in the fact that we do kind of a modified Cincinnati Pre-Hospital Stroke Scale. We pick 3 things and check it, and so that's how we check for a stroke. I believe the Cincinnati Pre-Hospital Stroke is speech, arm drift, and facial drift are the 3. So you can't teach an old dog new tricks. If they can say that clear, that's great. If they smile real big and they have a full smile, yeah, that's great. And if they have equal arm drift, that's great. And whenever you do an arm drift check, have them close their eyes and hold their arms up. People don't want to be sick, and so sometimes even whenever they are having a stroke, if their eyes are open, they're going to hold that weak side up. Whenever they close their arm or whenever they close their eyes, they can't feel it and it drops down, and then you know it's weak in that side. I say we do a modified version of that because we also will check grip strength. I think more people that I watch check grip strength than do arm grip. It's the same. It takes the same motor skill to do both of those. So if you have arm drift, you're going to have weak grip strength. So as long as you're checking like those 3 things, I say you're good to go. Whenever you document it, you just document either Cincinnati Stroke Scale negative or positive. And so I think nursing has a lot more in depth. Don't you guys have a lot more in depth stroke scale that you guys do, or stroke centers do anyway? Yeah, there's some of the hospitals that do this. It's a very in-depth stroke scale, and when you get in depth, you could really kind of narrow down where that stroke's even located, which is kind of cool, but unimportant for EMS. I mean, I don't need to say it's in the left hemisphere of the cerebellum, and no, that's cool. They're having a stroke. So anyway, so assessment of stroke, assess for speech difficulty. A stroke patient will often have slurred speech, use the wrong words, or be unable to speak at all. Cincinnati Pre-Hospital Stroke Scale. Ask the patient to close eyes and extend arms straight out in front for 10 seconds. If the arms drift, that's a positive sign for a stroke. There you are, old lady has her eyes closed. Assess for arm drift by asking the patient to close her eyes or their eyes and extend their arms, palms up for 10 seconds. The patient who has not suffered a stroke can usually hold their arms in an extended position with eyes closed. Sometimes you do this and they do this. You got to hold them up. Okay, whatever. There you go. Exactly. So, assess for arm drift by asking the patient to close their eyes, extend their arms, palms up, 10 seconds. So, that is, one arm will remain extended, but the other arm on the affected side will drift downward or turn over. Ask the patient to say something. You can't teach an old dog new tricks. Some people look at you funny and refuse to say it. I'm just telling you, they're really funny. Okay, you have clear speech. Does really good. You have slurred speech. For a conscious patient who can maintain airway, calm and reassure a patient, monitor airway, administer high concentration oxygen, Administer high concentration oxygen. Is oxygen saturation below 94%? Administer high concentration oxygen. Is oxygen saturation is below? Wow. Am I missing how to read that? Administer high concentration. Is oxygen if is below 94% up if signs of hypoxia or respiratory distress present. Okay. That is one of the worst fragmented sentences I've ever seen in my life. I'm pretty sure that they went to Alistair's second grade class and had him write this. So if the O2 sat is below 94%, they go ahead and I think it's or if signs of hypoxia. If the O2 sat is below 94%, or they're having signs of hypoxia or respiratory distress, go ahead and put them on oxygen. I'm going to say the book's probably going to tell you to do high flow O2 at 15 liters by non-breathing mask. I'd be careful with that. I wouldn't push it much past the 96 to 98% on this patient. You don't want let's see, oxygen, is it vasodilate or vasoconstrict? I'm trying to remember. Anyway, you don't want whichever one of those that oxygen can do, and then transport. For unconscious patient or patient who cannot maintain airway, maintain open airway, provide high concentration oxygen and transport. Transport suspected stroke patient to hospital with capabilities for managing stroke patient. Capabilities must include CT scan at a minimum. If let's say that you area that can't fly, you're not sure they had a stroke. We have a CT scan here, a very good CT scan, and they can tell whether they've had a stroke, and they can set up transport to an appropriate facility. Our stroke center in Oklahoma is Baptist. That's where most of the strokes go. I think most all the hospitals, large hospitals, are able to handle them, but Baptist kind of touts himself as a determine and document exact time of onset of symptoms. Document contact information of person other than patient provides time of onset. And I told you guys last known normal. That's the same thing as onset of symptoms. So I say last known normal because sometimes if you're asking about the onset of this, they think just the flat out stroke where they're drooling all over themselves. Oh, it's only been happening 10 minutes. Okay. He was acting kind of funny 8 hours ago. And so that's why you want to get last known normal. You'll get a more accurate answer. Document contact information of person other than patient provides time of onset. Can indicate serious dizziness or syncope. Can indicate serious or life-threatening problems. May be impossible to diagnose true cause of syncope and dizziness. Sometimes it's just an inner ear infection. Sometimes they were singing in choir and had their knees locked and passed out, right? I never passed out. Matter of fact, it's hard for people to get me. Have you guys ever seen them play the pass out where they take the whole breast and they push on your chest, or I don't know exactly now. It was really hard to get me to pass out like that. I've only done it once. It's some stupid thing kids do, right? So
I never would do it. I was too scared.
I was
what
too.
the hell? I don't wake up.
Well, I was
I was
too.
perfectly fine.
I was raised never going like that.
I was too, and so that's why I only did it. I was like, okay, gosh, I'll do it. But they tried, and they finally got me to it. And I never passed out on the bleachers. So dizziness, common term meaning different things to different people. Vertigo, sensation of surroundings spinning around you. And I think that's probably what most people consider dizziness is vertigo. Lightheadedness, sensation you're about to pass out, pre-syncope. Anybody ever stand up too fast and kind of everything kind of blacks out on you? That would be considered lightheadedness or a near syncopal episode. Do you call an ambulance?
My first rattle out of bed, as soon as I stand up, I'm dizzy on the out. I can't even walk.
So,
I
well,
was graduating and this girl was really on stage and this girl's coming up and I was looking at her and I was like, oh, and I jumped up and I run out, grab her because I could tell she was going. And I grab her and everybody's like looking at me and they're like, oh, and they're all there. And I'm like, well, she was like, come on, and stand.
syncope, brief loss of consciousness with spontaneous recovery, typically very short, a few seconds to a few minutes. Patient often has some warning that a syncopal episode, fainting spell, is about to occur. Cardiovascular causes. Bradycardia and tachycardia can cause decreased cardiac output and syncope. Vasovagal syncope is thought to be the result of stimulation of the vagus nerve, which signals the heart to slow down. A decreased cardiac output causes syncope. So you get the old men that are shaving, your vagus nerve runs right along your neck here. If you sit there and rub it and get it rubbed in the right place, you quite possibly could pass out from stimulating your vagus nerve. Another thing that happens is they're straining on the pot, they pass out, fall over, and hit their head. Or they die. Yeah, they bottom that foot. So. So that's a vasovagal maneuver. I didn't say this, but if you have somebody that you check their pulse and it's like 150, you have them bear down or try to blow their thumb up. I wouldn't do it very many times. Hey, try to blow your thumb up like this and see if you could get it to stimulate the vagus nerve and drop their heart rate. It does work. If it's truly a supraventricular tachycardia, which is not AFib, which AFib kind of comes from a different place, but truly an SVT. Okay, sounds good. If it's truly an SVT, you can vasovagal them down. It's not something that's within the EMT scope of practice. I wouldn't document it, and I wouldn't really make it known. I would just say, well, they had a high heart rate and it converted to this or whatever. But I had a guy that put a monitor on him, and he was in an SVT, nice, clean SVT. I think he's about 160, 170. And the protocol was always to have him bear down or do a vasovagal before we give adenosine. And it never works. So you just do it out of routine. Okay, I need you to act like you're blowing a balloon up with your thumb or whatever. And he did it and also nice. And I was like, whoa, that worked. And look, I caught it. But he had an episode about a year or two before. He said he felt the same way. By the time he got to the hospital, they didn't know what was wrong. They couldn't find it. And so luckily we captured it on our monitor, and we captured the conversion. And so he's able to go to a doctor and probably get on some medication for it, but at least it was. So hypovolemic causes of dizziness, low fluid, blood volume causes dizziness or syncope, especially when patient attempts to sit up or stand. Source of bleeding may not be obvious, so they might have a GI bleed or another type of bleed where you don't just see outward signs of blood. Metabolic and structural causes. Alteration in brain chemistry or structure can lead to diminished levels of consciousness. Metabolic and structural causes. Inner and middle ear problems also cause dizziness and syncope. I've seen some people get really sick because of an inner ear problem and battle it for a long time. I feel bad for them. Environmental toxicological causes. Alcohol and drugs can cause fluctuations in consciousness. Typically, the goal is to drink enough alcohol to lose consciousness, right? So we're just above losing consciousness, where you act like an idiot. So Other causes, in half of the cases, no cause is ever found. Patient assessment, rapidly identify and treat life threats. I'll just ask you guys, what do you think some life threats in a syncopal episode might be that you guys can find pretty quick? What are some signs that you guys might see in a syncopal episode that would indicate a life threat? Yeah, what are some things you might see that from a syncopal episode when you do your evaluation that might indicate this is a life-threatening situation?
You would do. Oh no, all the easy things would be, I guess, the stuff you notice right off the bat, like the dizzy, the speech, the normal.
No breathing is one.
Well, no breathing. Yeah, that's life-threatening.
I mean,
Some things that you guys would be able to see right away that would say this could be a life-threatening
fast
syncopal
heart
episode.
rate, slow heart rate.
There you go. Fast heart rate, slow heart rate, a blood pressure that's in the crapper. That doesn't rebound. So, sometimes you'll get there and they'll have orthostatic hypotension. So if they sit up or stand up, drops their blood pressure, which is typically a sign of hypovolemia. Whether it's they've had diarrhea and vomiting for days on end, have some sort of bleed that they haven't controlled. But sometimes just a simple fact of sitting up too fast, you kind of drop that blood pressure a little bit. You get there and you check it, and it usually goes up pretty quick. But you have the patient lays flat, they're fine. They sit up or stand up and they're dizzy and can't even stay sitting up. That's probably a good sign that they might have a life-threatening illness going on. You just can't stand up all day.
I think I have a lot of
You're gonna be that. What is that? Whenever people start to take, yes,
I haven't.
they self-diagnose themselves. I have cancer, and now I have.
It's just early mornings, and I think it's just because of my sugar. Early mornings.
Yeah.
When I step out of bed, I can't really function. I hit the walls and everything until I get a straight line.
So that's what I do until I get coffee. But anyway,
I can drink coffee also.
gather important information that will assist in overall treatment, and ask: have you had any similar episodes in the past, and what do you mean by dizziness? Ask: did you have any warning? When did it start? How long did it last? What position were you in when the episode occurred? Are you on medication for this kind of problem? Did you have any other signs or symptoms? Nausea? Did you witness any unpleasant sight or experience a strong emotion? Did you hurt yourself? Did anyone witness involuntary movements of the extremities like seizure? So Jacqueline, without warning, sometimes whenever they give her a shot or draw blood, she'll pass out. Me, I hate freaking needles, and I'm like, not quite that bad, but I hate needles. She doesn't even care. She's like, yeah, and then she'll pass out, and it's funny. I laugh. The nurses drawing her blood don't, and I'm like, she just passed out. And they're like, oh my god! What's that?
I've heard some of IVs that they don't let them know.
And you're probably not scared of them, not worried about it. It's just a whatever
The
reason.
best way for me not to pass out is I instruct the person what they're supposed to be doing and keep my mind focused on that.
Sure.
That makes them nervous.
So administer oxygen based on oxygen saturation levels and patient's level of distress.
Like, here, what are you doing?
Call for ALS. Loosen tight clothing around neck. Lay patient flat. Treat associated injuries patient may have incurred from fall. Is a seizure a syncope? Is a seizure or syncope a symptom of a large problem? TIA video. Probably not gonna play for us. Nope. All right. Chapter review, and then we'll take a break. So this ain't like the end of the chapter review, is it?
Yeah.
Oh, so we can go ahead and get into 20 tonight. That's 20? Oh man, we might get gonna kick some ass tonight. So
Just leave the test and walk.
no, you're just gonna fail, and I'm gonna tell Carol that everybody's failed. That's what I'm gonna do. I'm gonna fail all of you guys out, and then I'll just get paid because you guys are already paid, and we're just in class to die. That'd be awesome.
See if I let you eat my food.
What's that? Oh
I know, that's how we get you.
no, I already ate. I had some pepper things. I don't know. So, chapter review. Diabetic emergencies are usually caused by poor management of the patient's diabetes. Diabetics are probably the most non-compliant group of people ever. Diabetic emergencies are often brought about by hypoglycemia or low blood sugar. The chief sign of this hypoglycemia is altered mental status. I should clarify. Type 1 diabetics are super diligent. They're very good at it. Type 2s. So yeah.
And they want to eat the good food and drink the Mountain Dews and
And the booze.
my grandma was a boozer.
Oh.
She would eat everything that was
Yeah.
totally wrong.
Yeah.
Lots of salt, lots of sugar.
Grandma, they have a sugar-free version of that. That doesn't taste very good. Yeah, I'll have a hard time because I do like some wine and some beer and stuff like that. It's high sugar. I know, right? So whenever a patient has an altered mental status, a history of diabetes, and can swallow, administer oral glucose. I would check their blood sugar first. That's just me. Seizures may have a number of causes. Assess and treat for possible spinal injury, protect the patient's airway, and provide oxygen as needed. I'd only treat for spinal injuries if you have a mechanism of injury or index of suspicion. They had a seizure up on the roof and now they're on the ground. Okay, well, you might want to treat for spinal injury. Sitting in the doctor's office, had a seizure and slide out of their chair? Probably not. So, you should gather information about the seizure to give to hospital personnel. A stroke is caused when an artery in the brain is blocked or ruptures. Signs and symptoms of stroke commonly include an altered mental status, numbness or paralysis on one side, and difficulty with speech. For stroke patients, ensure an open airway and provide supplemental oxygen. Determine the exact time of onset of symptoms and transport promptly. Dizziness and syncope, fainting, may have a variety of causes. In the case of syncope, administer oxygen, loosen clothing around neck, and place patient flat with raised legs if there is no reason to treat. There's no reason not to. Treat any injuries and transport. Man, I need some sugar. Or maybe with my afternoon of working on a motorcycle, maybe I got into the booze, right? I didn't.
So what are you working on this motorcycle? Like, because it broke down and you're tweaking on it.
No, my speedometer broke down, so.
Was that one speedometer and license plate?
Yeah.
Right?
Yeah, I have another motorcycle that it doesn't run at all. I'm trying to get it to run. Determine if the patient's, and then I have another motorcycle that runs just fine, but now it's in shop getting silly. Determine if the patient's altered mental status is being caused by hypoxia. In a patient with hypoglycemia emergency, determine whether the mental status will allow the administration of oral glucose. Did we just talk about that? Oh, this is remember. Assess the seizure patient to determine the need for artificial ventilation. Determine when the symptoms of this stroke began. Last known normal. Remember that was your stroke. List the chief signs and symptoms of a diabetic emergency. Explain how you can determine a medical history of diabetes. Explain what treatment may be given by an EMT for a diabetic emergency and the criteria for giving it. Explain the care that should be given to a conscious and to an unconscious patient with suspected stroke. Basically, what you guys are going to do is both of them is address airway issues, right? So you're going to assess, get last known normal, treat any life-threatening injuries, and then concentrate on maintaining an open airway and adequate breathing. Explain the care that should be given to a patient who's experienced dizziness or syncope. Believe it or not, that's all I'm going to do for a stroke myself. I'll start an IV just because that's protocol. But as far as strokes, we don't differ that much now. So, a 62-year-old male is witnessed to have a tonic-clonic seizure. You find him actively seizing. His skin is pale and moist and slightly cyanotic. Discuss immediate treatment necessary. What does this guy need right now? What do you guys need to do? Air. You got to address that airway. Obviously, gloves on, seem safe. You want to make sure the patient doesn't hurt themselves, right? That's almost an immediate thing that happens. Once you get outside of natural history checklist, that all those things go away. But there are things that happen right now. But your first treatment on this patient is that airway, right? Good job on that. And so you're going to probably drop a nasal pharyngeal airway and use a back valve mask. Good job. Take a break.
So if you're doing that
Uh-huh.
and you have your list and you skip to do the air and then you just go back and redo whatever. I mean, like.
So you're saying if you're doing your national registry stations, as long as you hit all those parts before you make a transport determination,
Then you're good.
then you're good. Now, what I would highly recommend you not do is make a habit of doing it out of order or getting out of order, because as me as a tester, I can reach my goal sitting here. Me as a tester, if you can't get those in somewhat of the right order, and then you make a little mistake down here, okay, so if you're just nailing it, bam, 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 and I can tell you know what you're doing, and you do something stupid on the FEL criteria, like you forgot to say gloves on. You said scene safe, but you forgot to say gloves on. But you nailed that whole station. I mean, I could tell you know what you're doing. I'm probably not going to fail you. I'm probably going to pass you. As a matter of fact, I might say, is there anything else that you want to say? Oh, yeah, gloves on. All right, good job. Get out of here. But if you come in, you would say gloves on, and you're like, airway, I'm going to check the airway, make sure it's open, I guess. And then you're, oh yeah, scene safe, and maybe I need ALS, and you really kind of butchered. I could tell that you don't know that, and you didn't never say gloves on. Probably whenever you walk out and be like, didn't take BSI, tell me again. And so understand that's probably how it should be. But you guys, I'm hoping that we get to practice those quite a bit before you guys go into it, because they're not hard, and if you study or memorize those sheets, you'll be fine. I promise you'll be fine. If you don't study at all, and you go and try to study the night before or whatever, you're not going to do very well. So let me open up 20. Let's take a little bit of a break. Emilio said that he was kind of tired of hearing me talk for a minute, so he needed to take a break from me talking.
Is that right?
Just seeing if you're listening.
I always am.
So you're not watching movies and stuff?
Oh, I'm playing FIFA.
Okay. At least you're honest, man. At least you're honest. Let's see here. I think that's it. No, that's not it. Let's do this. Delete modify. There we go. That's what we need 20, right?
Yeah.
Oh,
I'm afraid.
See Camry's baby? See Camry had her baby early? Camry. Camry White. In the baby.
oh, she did have it?
Yeah.
I didn't know.
The 18th. Westland Eugene. You knew she was pregnant.
Fired every one of my employees.
Why? Because then you wouldn't have any of the extra shit to put up with or deal with or do. I said you wouldn't have all the extra shit to do then. You'd feel lost. Oh. I have this. It's like a. Oh, rose goes down. Okay. Oh, here. Hey, Regina.
What for?
I'm here. It's those two.
I told them, some poor was not big in her, she's gonna have something open for it.
Well, obviously, what side are you on?
I mean, it's supposed to be, they say it's a modern smiling muscle exercise, or what they call it.
That's.
Yeah,
You're-
they ripped that off the board.
Well, it's not even a blow up doll, there's, okay, we'll talk about that later. Oh, Aubrey's too young for those things. Aubrey's too young. Rob might be too young.
What?
I'm not dying. Yes, but Ellen, we know is too young. Ellen's too young for everything.
She, I was like, what?
Oh, come on. We're a kitchen. It doesn't. Oh, my God. Oh my God. Oh,
Oh, no, that.
hemorrhoid lips.
Okay.
My mind so didn't go there. My mind went to. My mind went to concrete. It really is. My mind went, hey, that's nice concrete. You know where my mind goes,
Oh, yeah.
so.
Yeah. I said, just saw
Sonic,
that
too.
can and be like, hey, you want one?
They're terrible. You see your sisters.
Oh, no, who was it? Who was it? I said something about, yeah, that would be awesome.
No, I don't actually think it would be awesome, but whatever.
I think it'd be hilarious.
I have a phone cord to it.
Yeah.
Here, I got a phone cord for you.
Oh,
If you just plug it to
we
the
need another
wall.
Rob needs a dang
I got some
plug.
right now, thank you, so.
And then,
It's gonna spread. I never leave that. Right there's the deal. Or,
I think Rob the lip stacker. Yeah.
yeah, so who wants to study this tool with me? I need to practice. I've been doing breast, I mean, I can't do breast now, I can't do now. I've been doing blood pressure.
I bet you could listen to mine and they don't sound right today.
So I figured I could hear like my dad and stepmom through smoke and she coughs a lot. I couldn't hardly hear her. I couldn't hardly get her blood pressure. Hers was so low. That I was like, and I said, I asked her, did you feel all right? She's like, no. I said, well, you shouldn't. She goes, I know my blood pressure was low, and I said, yeah. I mean, I could not, because I've been practicing, because, you know, I couldn't hear it on that stupid, I bought me a cuff. And I've been, I could go around and take it. I don't think it wasn't.
Well, on yesterday, you listen to that song, going on the road, and I thought, I can't hear everything. Well, of course, that's how you'll hear it. Well, I know that.
Oh,
Like,
so
that makes me laugh.
then my dad, I'm gonna buy my dad a stethoscope for Christmas, because he's like, put it right here. And I can hear the blood coming through it. I'm just listening to itself, and I'm like, I need a stethoscope for Christmas.
What?
Yeah. But he's like, you know, my dad's squirting through it. My daddy, really? He's like, I don't know, I don't like it. Tell him first of all, everything. Okay. So in consideration of our conversation from Sure. What about it?
Maybe. Maybe we should talk about it tomorrow.
Okay. How did you?
All I'm thinking about right now.
Hot fries, man. Oh, I got another buddy bar.
Oh, did you have to put it?
Because I stop blowing air at Rob's butt. Come on. I'm not frankly aggressive.
You should probably come on.
Well, let's you need the emergency service one in there. Yeah, no, it's fine. Blowing air.
Listen. That's on the phone.
What, dude?
It's not after hours, it's on call. Rob, it's not. You are. This is probably true, I know, but I'm not, your guy, I'm not getting blown by it. They, seriously. Be careful, some of that stuff's gonna be like a month.
I don't think I'm holding on.
We put food in there too. Years old. We did some ketchup out that outdated a year ago, not long ago. And the ketchup's outdated. That's how some of that's heavy.
Nobody better know our kids about that.
I know about the big ones at home.
I go by all the time. I'm sure like that.
Years ago, I was like, I liked them, but now all of a sudden, it's like 6 months, just bringing them home. I said, Body fit in them, so then. And I said, happy, yeah. I don't know.
All right.
Alright.
I was updating you guys on the assignments for you.
Oh, get back in there.
I didn't see what you're talking about, Serena? I didn't see what you're talking about, is it available now? I opened it, it is? Okay. All right.
That's my last test.
I just say, you can redo it.
No. You can redo a test for me. I flunked my last one.
Did you really flunk it?
I did it late and I was tired and had to be done.
No fucking excuses.
I flunked it. 66. I just flunked it. I mean, I really did. I just flunked it.
I knew I had to cover those things, but.
I opened all the way up back to chapter 12, to 427. So
All the way back to chapter 12.
I don't know what everybody needs. Everybody's like, hey, can you open this? Can you open that? Blah, blah, blah.
I need 18 posters.
18, that's why I had so long. Oh, not the post test. I did the post test. I passed everything but the chapter test.
Chris, all right. Allergic reactions. This one should be short because there's not a whole lot to it. Basically, you have allergens or that make you release histamine, and that's an allergic reaction. Good? All right. Chapter 20. I brought in some EpiPen trainers for you guys to check out. So. Yeah, there's no needle, but sure.
There's no needle on them.
No, I need to.
That's Stetson.
Whatever we said, you want them.
That's Stetson we carry them around.
Yeah, EpiPens actually hit very hard. I just gave Jacqueline all my EpiPens back, or I would have showed you guys. But they hit really hard. Thing about EpiPen, it's for you guys whenever you administer it, or for if you have somebody that you know that has one, make sure they don't just stick themselves and pull it out. They stick themselves, hold it for 10 seconds, and then pull it out. And it hurts because they thump. It's thump. They're designed to go through pants and into deep muscle. So they hit pretty hard, and it's a needle, and then it injects the thing. And it's into a big muscle. The one I use, I said everyone, the one I've used because I typically just use Epi out of the vial, but the one I've used, she cried. So, what's that? I know.
Made you feel terrible.
Well, she's kind of crying, trying not to cry, and I was like, "Is that hurt?" And she said, "Yeah, it's okay. I can breathe now." So
I've yet to use one.
you know, I was always oh, just like let me
No, I knew it. But I was like, oh, Brian, what did you do? No, how about I mean, I don't want to do this. I do not. This is gonna hurt. It's not like when your kid's taking and you're all around, you're like, yeah, I'm gonna do it. Yeah. Cut it out to me. It's so funny. It's like that. This little, didn't have it. And it's green, usually you start to kind of reading it blue. And 17, I couldn't feel it. You did it again. That's it. And pull it up. Push it down. I'm like, please go in the right place.
All right, so allergic reaction. So, immune system naturally responds to foreign substances in body. Allergic reaction, exaggerated response to foreign substance. Allergen is a substance causing an exaggerated effect. That's it. So, inside, first exposure, the immune system forms antibodies. The antibodies identify an attempt to attack particular foreign substance. Antibodies combine only with allergens they were formed in response to. So that's what I told you guys. You have to initially be exposed to something before you could be allergic to it, because if you haven't been exposed to it, you don't have antibodies. If you don't have antibodies, then you're not going to have that over-exaggerated immune response or the allergic reaction. Second, in subsequent exposures, antibodies exist. Antibody combines with allergen, leading to release of histamine and other chemicals into bloodstream. Chemicals cause harmful effects. Outside, effects of histamine and other chemicals, inflammation or swelling, bronchoconstriction and vasodilation. The bronchoconstriction is why they have the trouble breathing. Vasodilation is why you end up with the blood pressure dropping down. So anaphylaxis, severe life-threatening allergic reaction, can cause rapid dilation of blood vessels, which is going to cause that hypotension, right? So that's not good. Airway swelling. And so now you have, so what happens, let's just kind of think about this. What happens on vasodilation is the vessels all expand. So it's that, remember pipes, pudding, and pump scenario? So now you've taken a regular sized garden hose, nice flow, and you've now expanded it to a 2-inch or whatever those fire hoses are. Now that water or the blood is going to have a hard time flowing correctly. So what's the whole point of the blood? Carry oxygen, right? And it's all a pressurized system, and so it requires that pressure to get to different points. We vasodilate, we drop that blood pressure. What's happening with our oxygen carrying capability? Yeah, it's not going as well, right? We're not circulating as well. We're not perfusing as well. Couple that. So what typically happens when something like that happens? What's your body's response typically. Yeah, so you increase your breath, your respirations, right? And so your heart rate goes up, and typically you're going to vasoconstrict. But we have this thing that's causing vasodilation, okay? And so we already have a reason for being hypoxic. Well, why do we breathe faster? Take in more oxygen. But what happens with this anaphylactic reaction? We're closing off those airways, right? We can't take on that oxygen. So now we've attacked our whole system twofold. One, we're not able to get oxygen. Two, we're not able to circulate the oxygen because we have the vasoconstriction. So airway swelling, airway obstruction, and bronchoconstriction, and respiratory failure. So common allergens, so insects, foods, plants, medications, others, dust, makeup, soap, etc. Basically, if it's out there, you could be allergic to it, right? Some people are weird and allergic to some weird things, but you see a lot of people allergic to shellfish, bees, peanut butter. So, yeah, shellfish, that one. Anyway, hey, look at that. There's a shellfish. There's a peanut. There's a bee. No, it's like poison ivy. Substance that may cause allergic reaction. You know, I wish they wouldn't. This is common allergens, and then they write under substances that may cause allergic. Almost anything in this world could cause an allergic reaction. Another big one is like molds, spores, and things like that. So here's one that affects the healthcare community of the latex allergy. Your doctors, nurses, nurse aides, anybody that's in the healthcare field. Used to they had no. That used to you had everything was latex. You had latex tubing, latex gloves, latex underwear. Basically everything that touched your skin was latex, and so they're exposed to it. Now they're breaking out, and it becomes an allergen, and now they can't even wear their gloves. So many patients have latex sensitivities. Providers can develop latex allergy from prolonged exposure, and a lot of providers did. And now you're seeing almost everything has gone away from latex. I don't even know for the most part if there is much latex at all. Dishwashing gloves. You know what? I don't wash dishes on the ambulance. So, dishwashing gloves, stay away from them. No way to predict exact course of an allergic reaction. Severe reaction often takes place immediately, but can be delayed 30 minutes or more. Mild allergic reaction can rapidly progress to anaphylaxis. And then, you know, another thing for my beekeeping friends, I know that Amber keeps bees, and I just recently found out that one of my employees, Tyler, keeps bees, and he got stung, and his face is like all swollen up. But he said that usually it's never affected him like that. And this one really affected him. So just because you typically don't have problems from it doesn't mean you. Oh man, come on now! I hate autocorrect. It's become freaking more of a hindrance.
Yes, it does. Got like 10 texts right under that.
So anyway, moving on. Signs and symptoms of allergic reaction: itching, hives, flushing or red skin,
I
swelling.
have a question.
Okay.
On the hives deal,
Uh-huh.
and I think, and this would be a question for Ellen. Heston is not allergic to anything. And we gave him Bactrim because we were treating for staph. And after about, how many days was it, 10 days or whatever, he broke out in hives. Will they do it again, or was that just a reaction to the drug?
Yeah, you could do it again.
Well, I never give him Bactrim again, I'll do something different.
Well, and it just may be a side effect. There are
That's
some,
what I'm saying,
yeah.
it's side effect, you have to be on it for so long.
Who you talk to about that, who really knows, your pharmacist. Pharmacists are pretty good about knowing that stuff. Or the physician. Say, hey,
Well, see, the funny thing is you might have talked about any pharmacists, but I got half of it came from, and I'm sure all drugs are the same, I'm assuming, but half of it came from Wyoming, and then the other half came from here. I'm assuming it's the same thing. The name was different. I'm assuming it's the same thing. But it wasn't until he took that last little bit that he.
and so like you're different.
So I mean, it got built up. It got built up. It got built up.
It could be that, or different generics have different preservatives in it. So he
That's
might
what
be,
I'm saying.
he may be allergic to a certain preservative in it. And all what you'd want to do is if he's ever prescribed that medication again, is you'd want to say last time that he took it, he broke out in hives at the end of it. They might say that's normal. It's normal for you to break out. It's normal for people to break out in hives with Bactrim. It's not truly an allergic reaction. It's a normal thing. Or they might say, oh, you know what, we want to try something else. Now, there's certain things that you're going to give typically in a hospital situation. It's a life or death situation. If you don't give this medication, they're going to die, but they're allergic to it. They have ways of treating that allergic reaction.
I was just kind of curious if that considers him allergic.
You'd want to ask either the physician if he ever got it again, or a pharmacist, or you could look it up. You could say, does Bactrim cause hives? And Google knows everything. So,
Yeah.
So itching, hives, flushing, red skin, swelling in the face, warm, tingling feeling in the face, mouth, chest, or hands. Guys, just because they have something like hives doesn't mean they're going to have an anaphylactic reaction to it. Hives is just it's a systemic reaction throughout the whole body, and it's just an allergic reaction. Doesn't mean they're going to stop breathing or anything like that. Now, it can progress to that, but so can just a little mild rash on your arm can progress to next time you're exposed to it, you stop breathing. But you get some people that are like, oh, I'm definitely allergic to that. I get hives. Get definitely allergic to it is I've stopped breathing and they had to revive me. That's definitely allergic to it. So anyway, that kid looks like he has a rash. Signs of allergic reaction may include facial swelling. Swelling looks like around his eye there. Signs may include hives. Signs and symptoms: respiratory tightness in throat or chest, cough, rapid so this is whenever you're dealing with respiratory, that's when you are dealing with an anaphylactic type reaction. So tightness in throat or chest, cough, rapid labor or noisy breathing, hoarseness, muffled voice, loss of voice, stridor, and wheezing. I would associate all of these with an anaphylactic reaction. Cardiac, increased heart rate, and decreased blood pressure. Generalized finding: itchy, watery eyes, headache, runny nose, sense of impending doom. Dun, dun, dun. So, signs and symptoms of shock: altered mental status. So we're talking now. We're going to talk about what is shock and allergic reaction. What kind of shock is caused by allergic reaction? You could say anaphylactic shock, right?
That would work too.
So, what are the 4 types of shock? Yeah. Let's look it up, kids. There's hypovolemic. There's distributive.
Where's the shock? Where's the shock? Oh, it was back here. What chapter? 7?
Oh, do we hear? I heard one. Cardiogenic, there's one. Hemorrhagic, hypovolemic. No, you're on the whole big list.
He gets them all.
There it is. What is you had said obstructive, right? I know, I heard you. So okay, so Ellen, repeat what the 4 types are. So what is anaphylactic reaction fall under? Which one of those? Doesn't it say? Thoracic bone to be sure. All right, so it's a distributive shock, and it's because it's defined by that because it causes those vessels to dilate, right? You guys want to make sure you know at least those 4 types of shock and why each one is that way. All right. I know, freaking how. So what I just showed you is that once you finish this class, don't stop studying because all this stuff will be on National Registry again. Okay. So anyway, signs and symptoms of shock: altered mental status, flushed, dry skin or pale, cool, clammy skin, nausea or vomiting, changes in vital signs, increased pulse and respiration or decreased blood pressure. Any of the previous signs and symptoms can be associated with an allergic reaction. Anaphylaxis: patient has either respiratory distress or signs and symptoms of shock. All right. So any of these signs of shock. Altered mental status: flushed, dry skin or pale, cool, clammy skin. Nausea or vomiting. Changes in vital signs to include increased pulse and respiration, decreased blood pressure. If they have those, they're starting to get into the anaphylactic realm. All right. Primary assessment: identify and treat life-threatening problems. Airway, breathing, circulation. All right. How are you going to treat airway, breathing, and circulation in an anaphylactic shock? How are you going to get them air if they're closing off? Everything. EpiPen.
It'll open up, then you can get in there.
It'll work. Repeat if it doesn't. Repeat the 2 of them. If the first one doesn't work, you can give them a second. It will work. Aggressive airway management, if it absolutely doesn't work for whatever reason, they're deathly allergic to peanuts, and they had this crazy ass reaction. And what's that? Yeah, you can get 2, but aggressive airway management, and yeah, maybe what's another one besides call for medical direction? Contact ALS, right? Try to get ALS to meet up with you. I don't know why it's like that. My phone gets noisy sometimes. All right. Secondary assessment: history of allergies and exposure. What was the patient exposed to? How? What method route was the patient exposed? Signs and symptoms, progression, and intervention. Assess baseline vital signs, obtain the remainder of past medical history. Go back to that last one. Thought they're going to let talk this a little bit more. So, secondary assessment. So, history of allergy. Do they have a history of this? What, and another thing that you want to find out is what kind of reaction do you typically have? If they just typically have hives or a localized rash, it's a lot different than if they typically have an airway issue, go into distributive shock. Exposure, what was the patient exposed to? Obviously, just because they're stung doesn't mean that they're stung by the critter that gives them an allergic reaction. A bee sting is different than a wasp sting, right, Amber? Right there. So you get somebody that's allergic to bees and they get stung by a wasp. Sometimes they just freak out. It's like, oh my God, I got stung, and they don't know that there's a difference. So you want to, if at all possible, know what the patient was exposed to. How or what method or route was the patient exposed? That's kind of obvious. The bee sting, obviously, it was an injection, right? If it was peanuts, I guess you have different ways because people could just come in contact with peanuts. But let's say that they wanted to get crazy and they ate the peanuts that they're allergic to. So you want to know, right? And just because, let's say that they are allergic to bees, definitely allergic to bees, they're 100% sure they were stung by a bee because they're collecting honey. So they call you because they didn't want to pay the $500 or whatever EpiPen costs now. And so they call you, you show up. Are you going to hit them with the EpiPen right away? No, if they're still breathing, they don't have those signs and symptoms, just monitor them. We had a crew that did a really good job. I was really proud of them for doing it. They got called to a guy that was definitely allergic to wasps. He was stung by a wasp. They get there. He was obviously stung by something, and he had the sting. And they just had the EpiPen out, but they just monitored him all the way in, and they didn't end up giving it because he never really showed signs of having respiratory distress. He really didn't have any signs besides the sting of having any allergic reaction. And so don't get real excited and give an EpiPen just because they're allergic to it and just because they're exposed to it. Make sure that there's a reason for it. Now, you've seen in the slide earlier, it could be delayed up to 30 minutes from exposure. So obviously you don't want to say, you'll be fine. Go ahead, drive on up into the bend of the river where nobody can get to you. It'll be all right. Because that takes about 30 minutes to get there. But anyway, you want to try to convince them, you know what, maybe you need to go in and get checked out since you are allergic to bees or wasps and you were stung by a bee or wasp. And you might let them know, it can be delayed, the reaction can be delayed. And so if they completely refuse, is there somebody that could stay with you for the next 30 minutes to an hour? Just so you're covering your bases. What did you just do by telling them those things before you got a refusal? Covering your butt. But it was an informed. It was an informed refusal. You informed them that, hey, I'm really kind of advising you that you need to go get checked out here. You need to tell them that. But you gave them the information that, hey, this could be delayed and you could have a problem. And you did everything to CYA. And so I'm kind of adding some of the previous chapters tonight. Maybe I should do that more often because you guys are like, what? So, we're actually getting into some chapters where we can start doing that. Before we're learning kind of the other crap. But now we're going to start getting into chapters where we can do that. I think, what's the next chapter? Chapter 20?
21?
Hot damn.
Sorry, that's another minute.
Poisoning. Yeah, so, we should be able to start incorporating other chapters. So, patient assessment, assess baseline vital signs, obtain remainder of past medical history. Thank you. So manage patient's airway and breathing if they need it, right? You're going to at least monitor it. Apply high concentration oxygen if patient is in distress or appears to be having an anaphylactic reaction. Mild allergic reactions do not require oxygen or epi, all right? Me? You might tell them to go get some Benadryl. So anyway, if not breathing, adequately provide artificial ventilation. Consider assisting patient with epinephrine auto-injectors. You guys can actually get one off the ambulance and use it. That is a local protocol, state protocol. If patient is not wheezing or showing signs of respiratory distress or shock, continue with assessment. Consult medical direction regarding use of auto-injectors. Our medical direction here and how the state of Oklahoma is written is you don't have to consult them if you don't have a reason to. So if they're not having trouble breathing, there's no reason to consult them. As a matter of fact, if there is a reason to use this, you don't have to consult them. You just use it. All right? So I wish they would kind of get away from some of these protocol-related statements that they have in here because you guys won't see protocol-related statements in the natural stuff, or you shouldn't. You shouldn't see contact medical direction for X, Y, and Z. When use of auto-injector may be appropriate. If patient has come in contact with substance that causes allergic reaction in the past, no, don't use it then. What? It may be appropriate if they have an allergic reaction. If patient also has respiratory distress or exhibits signs and symptoms of shock, yes, that's when you use it. After using auto-injector, record administration of auto-injector, transport patient, and reassess every 2 minutes. What the? If by reassess every 2 minutes, they mean by look at your patient every 2 minutes, okay. But I'm not going to check vitals. I'm not going to check respirations. I'm not going to do all that crap every 2 minutes. Sorry. Ellen was with me the other day. You eat up a lot of time doing other things that need to get done. You're not going to be able to take vital signs every 2 minutes. Or you're going to go up to the hospital and they're going to be like, what'd you do? And you're like, well, I reassessed them every 2 minutes. That's all I did. Kept them alive. Sometimes that's the most important thing. Perform a reassessment, paying special attention to the patient's ABCs and vital signs in or out to the hospital. So obviously, right? And guys, if you notice they stop breathing, you don't have to wait to the 2 or 5 minute mark, however often you're assessing. If you notice they stop breathing, just go ahead and start treating them right then, all right?
We cannot reassess.
I have yet to reassess you, therefore I cannot treat you. So, all right. Should you administer an auto-injector for, think about it, should you administer an auto-injector for a simple allergic reaction? No. Are they dangerous? Let me ask you that. Why are they dangerous?
They speed up your heart rate.
Okay. You have epinephrine naturally found in your body.
Yeah, but if your body's building it and you give artificial, you get double dose.
I'll tell you when it can be dangerous. You're right. It definitely can be dangerous. If they have an underlying heart condition that maybe hasn't been exposed, so you have these kids that have these heart diseases, you might expose it whenever you get epinephrine. That's not good. That's whoa crap. What's that? The auto-injector? Yeah. That might be bad. That would be. You might knock out some things you might knock out. But the other thing is elderly patients who their heart is already a little weaker and a little more susceptible to adrenaline anyway. You might not. I'm not saying you might not. You may want to contact medical direction, but that's a situation where it could be dangerous for those patients. So, a normal, healthy, 8 to 60-year-old patient, you're probably going to be fine getting epinephrine too. Okay. On a risk to reward ratio, this is highly beneficial compared to the risk that you run of causing a problem. So don't let the fear of an underlying cardiac issue keep you from giving an EpiPen to a patient that needs it. Just make sure they need it. If they need it and kill them with it, well, oops. Try to get them back. That's a bad deal. Breathe again. Yeah. So anyway, So anyway, EpiPens are relatively harmless, but there is an element, just like anything else, there is an element of safety. So, I'm not gonna watch the video. Achoo! Self-administered epinephrine. Commonly prescribed to patients with a history of allergy. Auto-injectors are common for people to carry or have at home. Hormone produced by body, constricts blood vessels, dilates the bronchioles. If they did give it to themselves, you may check the expiration date. If it doesn't seem to have worked, and you might ask them how they gave it to them. You know, how did you administer it? Well, I poked at my leg, and did you hold it? No, I didn't. Well, then you read it, then did you? But you want to see why it didn't work. Then you may consider going ahead and using yours. If authorized by medical direction, you can administer or help patient administer a dose of epinephrine from auto-injector that has been prescribed for a patient by a physician. You can pull it off of our shelf of our ambulance and use it. It's a little different than the nitro. Side effects: increased heart rate and increased cardiac workload. That's where the workload is where you get in trouble with the elderly and the people with underlying heart conditions. Administering auto-injector, spring-loaded needle and syringe with a single dose of epinephrine. Upon administration, medication automatically releases and injects. This is what they kind of look like, and this is probably more accurate than what they look like now. They're more of a oblong, unless you go with the generic, which the generic does look like this. There is a generic now. I'm hoping that they get a few more. What's that? Yeah, so yours would be an EpiPen. The brand. They actually have another EpiPen that is another generic, because this is actually a generic. They're both generic. But the other one is a round one that looks kind of like this. Administering auto-injector, obtain patient's prescribed auto-injector and ensure prescription is written for patient, right? Patient, right? Medication is not discolored. Medication has not expired. Obtain order from medical direction. Remove safe check. You still want to make sure you have your 5 rights. What are your 5 rights? Something like that, right? So, press tip of auto injector firmly against patient's thigh, outside of thigh, midway between knee and waist. Hold injector in place until medication is injected. 10 seconds. Let me see here. It even says on the package, 10 seconds. And every 2 minutes. Administer auto injector, record administration in time. Carefully dispose of single dose injector in biohazard container. Save 2 dose injectors. In one pen? Okay, cool. That sounds complicated. Like I would die. Reassessment may show patient condition deteriorating. Additional doses of epinephrine may be necessary. Told you guys that already. Required online medical control. I wish I'd leave these words requires online medical control out, because this is more of a protocol issue rather than a teaching point. Requires bringing patients additional auto-injector in the ambulance. Okay, we have them. What's that? There we go. There's our 5 rights. Yeah, we're including all kinds of stuff tonight. If no auto injector available, request ALS intercept, treat for shock. How do we treat for shock? Yeah. You basically you're gonna lay them down flat. You're gonna keep them warm, and you're gonna airway, right? That's all we're gonna do at the basic level for treating for shock. Good job. 2 sizes of auto injectors. Adult is 0.3 milligrams. Child dose for children less than 66 pounds is 0.15 milligrams. So about half, exactly half the dose. Chapter review. So chapter review. Yeah, point 3 and point 1.5. Allergic reactions are common. Anaphylaxis is a true life-threatening allergic reaction. It is rare. Yeah, you don't see a lot of anaphylactic reactions. You see lots of allergic reactions. The most common symptom in these cases is itching. Patients with anaphylaxis will also display life-threatening difficulty breathing and/or signs and symptoms of shock. Patients with anaphylaxis will be extremely anxious. Their bodies are in trouble and are letting you know it. So if you guys get somebody, and not because they're worked up, but they're anxious, you really want to try to get them to go with you because there is a chance that they're going into shock. Okay, so don't just look for the breathing difficulty. Also look for your signs of shock, which are
Sound of shock,
what are signs of shock?
your heart rate.
Yeah, so you increase heart rate, increase your respirations, decrease blood pressure, color. Yeah, so moving on. If you have any of those, the signs and symptoms of anaphylaxis result from physiological changes, vasodilation, bronchoconstriction, leaky capillaries, and thick mucus. Oh man, we have thick mucus in my toes there. By quickly recognizing the condition, consulting medical direction, and administering the appropriate treatment, you can literally make the difference between life and death for each patient. Literally. You can. I'm a jaded, burnout paramedic. I feel like there's very few things that I could change an outcome of a patient. This is one. This is one that I do believe that you change the outcome of the patient. Allergic reactions, severe asthma attacks, basically anything with the airway. Is a few things that we actually change the outcome. I don't believe we change much the outcome of trauma. I don't. I think we could do things right and increase their chances of survival, but I've seen it time and time again that I do everything right and they die. I do everything wrong, mess up. Not always. Do everything wrong. The call went like crap. There's delayed getting to a trauma center. I just knew that we're never going to see it again, and then we see them again perfectly fine. And so, I have a jaded view of things. Does that mean don't try to do things? No, I try to do things right because I want to give them every chance that the studies show. But EMS wise, I do believe that these patients are some of the patients that you, even at the basic level, make a huge difference. All right. Move on. In allergic reaction, the body's immune system overreacts to an allergen and causes potentially harmful side effects. Anaphylaxis is a severe systemic form of allergic reaction, is a life-threatening emergency. EMTs must use assessment to differentiate a localized allergic reaction from a systemic anaphylactic reaction. Epinephrine is useful in anaphylaxis because it constricts dilated blood vessels and opens bronchial passages. It does the exact opposite of what that anaphylactic reaction does, right? Anaphylaxis dilates the blood vessels and constricts the airways. Epinephrine does the opposite. So. Epinephrine has potentially dangerous side effects and should be used only in the event of anaphylaxis, extreme asthma attack. What are the indications for administration of an epinephrine autoinjector? What are you looking for to say, okay, I'm going to treat this with an autoinjector? Not breathing, respiratory distress. Okay. Shock, right? So, yeah, low blood pressure, high heart rate, high respirations. So you're looking for those signs of shock. Altered level of consciousness. So, list some of the more common causes of allergic reactions. I don't really care. Food, plants, bugs, and medications. List signs and symptoms of an anaphylactic reaction associated with each of the following. Yeah, but there's list signs and symptoms of an anaphylactic reaction associated with. You know what? Just tell me what you see on the skin for an allergic reaction. Yeah, hives, urticaria, any type of rash.
Oh, hi.
Urticaria is basically hives. It's a raised, itchy rash type.
Or just know that.
Was that in there? Was that word in there?
It's in
I
one of
haven't
those.
read it, so.
I didn't want to know when I get stung by a doctor. Within 5 minutes, it weighs all the way every inch of my, literally every square inch of my body, head to toe.
Literally.
Literally.
I just said that because of that.
Literally.
Yes.
Respiratory system. What are you going to see in an anaphylactic reaction? Yeah. Wheezing, absent breath sounds. Absent breath sounds are ominous, right? So they're not able to get any air in, any air out. That is an ominous sign. Same, yeah. I'm going to throw that absence of breath sound, so you got to listen. You don't hear anything. That they're shut down. It's an ominous sign. You also see that in your. You can also see that in your asthma patients too. If you have a patient with severe asthma. So cardiovascular system. What are you guys seeing in the cardiovascular system? Increased heart rate and decreased. All right, good job. Yay! You guys are starting to good saying. Good job.
You're finally making it.
So, all right. So, critical thinking. A 24-year-old male ate a meal that he believes contained shellfish. He's allergic to shrimp. Idiot. He is sweating and nervous. He appears to be breathing adequately. You do not know any wheezing or stridor. Watching. Okay, but what is a tail sign that we need to watch on this scenario? Okay, he says he's allergic to it. Nervous. That anxiety, that anxiousness is one of the first signs you'll see in shock. It's the first test to the mental status. That anxiety, next thing you know, they could go progress. So yes, you have that now. Could it be just that he's nervous because he thinks he ate some? Yes, definitely. So you don't want to just poke him with a EpiPen.
You're nervous.
Yeah, exactly.
I'm nervous.
Exactly.
We're all need a shot of Epi.
You go to take your national registry test, and you're like, "Oh my gosh, I'm having an allergic reaction." So yeah, but the fact that he is allergic to it, he does have an idea that he ate it, and that nervousness would tell me that I at least need to watch him. Do I need to do an EpiPen right now? No. If it progresses to an altered mental status, or we see the other things, the decreased blood pressure, increased heart rate, increased respiration, we see the signs of shock, yes, then we're going to go ahead and treat with epinephrine. His face is slightly red, his pulse is 88, strong and regular, respiration 24, blood pressure 108/74, and skin is warm and moist. Should you administer epinephrine? I'm still going to say no, even though you're starting to see some of those signs and symptoms of shock, right? The skin is moist, the warm and moist skin, so we have that vasodilation. Could be because he's nervous.
Some people are quite like that.
Exactly. Could be. So we don't necessarily need to jump on top of this yet, right? So now, that's all we talked about why we did it. I'm done for the night. You want to do 21? Okay. That's fine. Where does finishing 21 put us? Week wise. I'm gonna take a break though, because I gotta
I know 20's not due till like May, like 11. So.
I
25 pages in
I need to download it anyway. So
Yeah, I need to go take some read and put some suggestions and stuff.
what schedule wise, where does getting through chapter 20 put us? When were we supposed to do chapter 20?
20 is doing chapter 20
was
was
on
on
9.
19 was the night.
chapter 1 was
Oh, awesome. So we can really jump up here.
So if we get all this done, we need to do,
No, we need to get, okay, so we,
Well, Tuesday, yeah, we need to do some of the crap we're learning.
no, and here's what we're gonna do. We need to get through it because we need to start on our national registry check sheet. All right, you guys got a vital sign lab. In the national registry check sheets, you'll get splinting and spine boards and stuff like that. And so lab wise, I'll have to go look and see what their lab schedule is. Some of the labs are kind of hokey, like taking off your gloves and crap like that. But whenever I go through and read the labs, sometimes I'll find like, oh yeah, we really do need to hit that. And I'll look through them, and if there are some, we will make sure we hit them. But we will have a lab on Tuesday. It's just going to be lab. It's going to be CPR, and then we'll run some codes. But I do want to get done with the chapters because I want to start working on the National Registry check sheets, which will be lab nights. Then it will all be lab. So I won't be sitting here me blabbing. During that time, though, you guys will be needing to finish up your ride-alongs and stuff like that. And you guys will
Then
want.
I have a suggestion. Honestly, I have a suggestion.
No, that's fine.
I don't know. Why don't, if you do that and you want everybody to get through the chapters, why don't you just leave all the stuff unlocked so we can just work on it?
Because it is, you can go in and open it up and work
Well,
on
but
it.
I mean, if you get behind those, right, I mean, try to make it to where we're caught up, but.
Because if I don't have those dates and I'm making you guys ask me for it, you guys are going to stay caught up. I've had the open no deadlines type class before, and what happens is Serena's like, you know what, I got to work tonight. I'm not gonna do it. But whenever Serena has to say, hey Rob, can you open that chapter up for me? She doesn't like doing that, right? And even if you realize it or not, you're going to try to hit that deadline. And that's why I keep the deadline. I will work with you
They
guys.
want us to ask, so we make sure to do it.
So, well, yes, I want that because,
I'm good with it, I just,
and I thought about doing that. I thought about, like, it's easier on me just to open them all up. But I've done the full open course, and what ends up happening is,
doesn't work out for you.
it does, not that it doesn't work out for me.
Well, for the person.
It doesn't work out for the students because
Any
of,
normal person would try to keep up, I know. You shouldn't get behind.
but it's easy. Humans are procrastinators, and it's easy to say, you know what? I got this rad tech assignment or this English assignment I got to write. I'll do it tomorrow. There's a rodeo. I'll do it after the rodeo. Oh, we're gonna go hunting. We're gonna go,
You know what I did for that reason? I fixed my iPad so I can use I don't have data, but use the satellite, so when I am gone, I can still take my test.
So EpiPen, right? Since I got the trainers out,
Wow.
these are a lot like this. It has a safety device. So you'll pull the lock out, all right? Like I said, don't put your thumb on it, and even though you know that you have the right. You hold the EpiPen with your hand like this. If you come down like this on accident, it doesn't go off. Oh, look. You didn't have your thumb in the back, right? You just put it over. So they're designed right in the middle of the thigh, right? For an individual to do it themselves and the thigh. 1, 2, 3, 4, 5, 6, 7, 8. But this is probably one of the biggest things I could tell you guys. Because people have stopped themselves in some and then you're doing it to the patient, well, now you got it, and the patient, and you kind of hurt. It really hurt. I mean, you know, might be an IO. Yeah, I get it. For the people out there in the internet's land, do you guys have any questions for me? I think it's just probably Emilio.
I don't want to do it, but I had an EpiPen at home, and
I went to change this package and I went to take it out and put it in my.
You hear it on that side?
One of the kids got home getting up with it.
Oh, yeah. So Amelia, I'm done for tonight. Lab on Tuesday. Come for CPR, please.
Okay.
So, you have any questions or anything?
No, I don't. Except you told us to tell you if we needed a certain Saturday that we couldn't make it. I'm not gonna be able to make it the 6th. I don't know if you have something going on or.
Okay, I'll make sure I don't do a lab that day. We'll still have
Okay.
class. I won't do lab that day.
Right. Yeah.
I have. You're not the only one on the 6th.
Okay.
So there's actually a couple. They're going to be on be gone on the 6th, and that's cool. I'll try to make sure. I've been doing pretty good at getting the YouTube thing fired up, so it should be there if you want to do it. If you feel like
Yeah, I
it.
will.
So, all right, man. I'll see you. I'll see you Tuesday.
Alrighty.
All right,
See you later.
take it easy.